of us trio, Noopur's the expert, but I'll give you my non-expert view because I have to put it with Maurizio on a day-to-day basis. So
Okay.
he has unequivocally shown me large lytic lesions that have healed, where you can see the bone coming back, which is almost heresy to say that, but it's in patients who've had very deep responses, and so that's important, no disease. And these new agents, both IMiD drugs like Revlimid and proteasome inhibitors, also have pro-bone growth effects that nobody expected, but actually is there.
But I haven't had the survey, the bone survey.
No, absolutely.
So I have to grab it off me because I didn't talk too much.
No, you have both Gareth and Faith who've done a lot of work with bone disease as well. So, but you're absolutely right. With all the new drugs we have today, I think the key to myeloma treatment and also myeloma treatment for bone disease is being on these novel agents. So the proteasome inhibitors, for example, Zangari's Ninlaro study probably is going to have bone effects. We've shown in the lab a long time ago that all of these drugs can heal bones. So what was conventionally thought would never happen will happen. Having said that, in the future, I think we're going to get even more powerful drugs to do that same job. So when I was showing you that slide where you have those bone forming cells which don't exist in myeloma, or they're really suppressed, and that's why you end up with these holes. We now have drugs which can actually help those bone healing cells to form. So bone anabolic agents are in the clinic as we speak. So we're very hopeful. So in addition to whatever you're doing for your myeloma treatment, you should be on a bisphosphonate. Both Gareth and Faith here have shown that zoledronic acid is a great drug, and you should be getting that once a month, and after a few months we actually do tend to back off. There's another new monoclonal antibody which you're going to hear about soon. The drug's called denosumab. The difference between zoledronic acid and denosumab is it's a drug which can be given under the skin, so you don't have to go through an infusion. And I do think that that drug is going to be specifically useful in people who have kidney-related problems. And again, very potent. And all of these drugs, they've shown first when they were in England that these drugs also have some anti-myeloma activity. So in addition to helping your bones, they help your myeloma as well. So all good things. The other couple of things which I might add is, make sure your calcium levels are okay. Once you're on these bone-targeted agents, you need to be taking some calcium by mouth. And the other thing which I think is very underappreciated is vitamin D levels. So make sure that your doctors check your vitamin D levels, because all of these drugs work better if you're calcium replete and you're vitamin D replete. Make sure you're taking supplemental vitamin D if your vitamin D levels are low. And a lot of our patients need the higher dose. Once you get vitamin D replete, I think what's required by most people, the WHO has come up with guidelines. You should be getting 2,000 units a day irrespective. So once you take the high dose, don't stop it. You need to be continued on it. With myeloma, you tend to need more. So I'm not surprised that you need more than what you're on.
Yeah, so as they've said, there's the anti-myeloma effects of anti-bone effects of the actual myeloma therapy itself. That's important. Then there's the protective effects of the bone agents that we've been using. So the old ones that stop the bone disease, but then these newer ones that are coming on that are helping to build the bone. There's obviously the calcium and the vitamin D. I guess the fourth bit I'd add on to that is exercise. Okay, don't forget how important if you can, weight-bearing exercise is in strengthening the bones, but also strengthening those muscles that are around the bones. That's really important as well.
Dr. Davies, I know you did a lot of studies on bisphosphonates And do they have any effect on the myeloma?
Yes, so as Noopur mentioned, in the study we did in the UK, we looked at 1,000 patients, and those patients that were on the zoledronic acid, the Zometa, I can't even pronounce it in my American accent now. Zometa, there we go, the Zometa. It actually did seem to have an effect against the myeloma as well. So it seemed to be like a really double whammy. You got some protection for the bones and some effect against the myeloma.
Yeah, so, obviously we're very excited about it. We still have to make sure that it is the right test. The gold standard has been the bone marrow to date, and we're working with the liquid biopsies. There's a lot we can do at the single cell level, even at just the circulating DNA level, which I didn't show you any of. But I think it's important for us to now, when you have these tools, to go back and compare it to the gold standard. So that's the process we are going through right now. So I don't think we're quite ready to replace it just as yet. We want to make sure that the information we are getting is accurate and that we are not missing things by using blood. So I do think in the next, say, 2-3 years, we'll be working on this. So this is already becoming part of some of the clinical trials that we're doing going forward. And once we can validate these tests, and then show you how specific they are and how sensitive they are, that's when it comes to use in everyday routine. But you're absolutely right, it is so inconvenient, and we do appreciate that.
So that's just like there's technical detail in all of this, and so I'm convinced and can be technically correct that using circulating DNA, you'll never be as sensitive as doing a bone marrow test. It's theoretically impossible. If you had a way of capturing circulating cells, and then you could enrich for the circulating cells and then look, then there's some potential to get the test to be more sensitive. But that's a way off and is going to need a lot of technical development.
Yeah, I just wanted to come back to this clinical trial thing, because this area is one that's really ripe for clinical trials, and it can be. It sounds awful, but from a patient's perspective, it's quite easy to get involved. If you're a patient, it is going to one of the research centres, and I know Arkansas and I know Noopur's centre has the same. Often what we'll ask for is for a little bit extra of the bone marrow or the blood test, okay? And certainly in Arkansas, what we're doing is that sample goes up to the 12th floor, okay, where there's a large lab. And essentially what we're doing is that we're running these tests, trying to develop and use the blood test, and we're pairing it with the bone marrow tests that you've given us, okay? The idea being that we'll then have a group of patients where we've got the bone marrow test, we've got the blood sample, but we've also potentially got the imaging test, be it a PET or an MRI, and we can look at the patients and try and figure out exactly, are we getting enough additional information? Are we capturing everything we need if we give up one of those tests? Okay, and there's many centres that are doing that. And so if you ever are asked, and I know it's a lot to ask for, I'm not saying that, but if you ever ask for an extra blood test or something, that's the kind of studies that those tests are going to look at. Okay, and I think we're not there yet, but what we really need to do is to not only compare it to the bone marrow test, but compare it to those imaging as well, and say, can we get rid of it? Because I think the doctors as well as the patients would love to, if not get rid of it completely, narrow the number of patients down that need to have it.
No, it's stupid, because you're right. Why would there ever be a single threshold? Biology doesn't work on thresholds where somebody says, it's 10%, you have 10% to be myeloma, below 10% you're muggus. Doesn't make sense. Similarly for residual disease, it's a continuous variable, and that variable probably goes from 10 to the minus 3 to 10 to the minus 6, because those are the only, the level or the range of sensitivity in the test. You can never get below 10 to the minus 6. You should see it as like, the deeper you get, the better your outcome, with a number of exceptions. And the exceptions is if it's behaving like muggers, because there's a proportion of patients that can have disease that's stable, doesn't change for decades. But no, it's a continuous variable. Deeper you get, better you do.
I guess I just wanted to add to that it's important to know when people say you are MRD negative or MRD positive, what tests they've used and what their sensitivity is. Because there was a really interesting study done by Ola Langren in New York, and he looked at lots of labs around the country, and he asked them, are you doing this test? And many of them said yes. And then he said, so what do you call MRD positive and what do you call MRD negative? And they all had a different answer. Okay. And so it's really important, and it's something that as doctors we're learning. And I've actually been at a couple of meetings recently with my colleagues where as doctors we're discussing, what level should we be calling this, and what does it mean for patients. And I think the overall conclusion is, exactly as Gareth said, it's a continuum, and we need to just say, oh, it was negative to this level. Okay. Because one assumes maybe next year, maybe the year after, we'll have a better test and we'll be able to measure it lower.
So I think those are all good questions, and Gareth and Faith have answered them in some ways. And the only thing I'm going to add is, the honest answer is I don't think we know. What we have, based on the technology we have available to us today, we know we can go to 1 in a million cells right now. And we can detect up to that based on if you use next generation sequencing or you use a next generation flow, whatever the method is. So part of the reason, and I just want to put MRD in a little bit of a perspective here. Why is it that we are so going into MRD right now? Dr. Morgan showed you a very nice slide showing you that we're seeing 100% of our patients responding to treatment right now when you start combining the drugs. And then how can you make, if everybody is responding, how do you make distinctions between that response? So looking at that response and looking at finer details like MRD. So MRD right now is only a better tool of understanding the depth of response, and it has to be in the context of what is the treatment you've used, what is the technology you've used. And Faith is absolutely right. 2 years down the line, we will say we're going to find 1 in, God knows, 10 million cells. We are not quite there, so we'll see. So this is a moving target, and I don't know if we are basing any of our decisions of treat or not treat just as yet on that MRD testing. And that's the one thing which I think we need to back away from a little bit. We have trials right now in place looking at these technologies and seeing whether or not we can either escalate or de-escalate treatment based on this testing. But I don't think it's ready for prime time just as yet.
Think of your whole bone marrow cake, which is like 3 bags of sugar full of cells, of which 1 grain is 1 grain is positive. You can only find that 1 grain if you looked at all of them. So if you sampled it, you'd always miss it. So some of it doesn't make sense. You don't want a test or don't need a test that's more sensitive than 1 cell in a million, because you then have to put a needle there, you have to put a needle there, you have to put a needle there, then you'd have to take the whole bone marrow out and look at all of that. So the logic of it doesn't carry on, and so you have to combine MRD detection with a scanning technology that looks for a lump somewhere or a focal lesion. So the combination of the two is the optimum way forward.
So I was going to say you're now going to get 3 different answers, but I'm hoping that Dr. Morgan and my answer's the same. So you're potentially going to get two different answers, okay? Because I think the answer, exactly as you said, what is standard? The answer is we currently don't really have a standard, and it depends where you go as to what kind of genetic testing you get, okay? And again, just as there's lots of work going on, not only in the US, but worldwide, standardizing all of these things, okay? Trying to work out what is the minimum we should do for MRD or the minimum we should do for genetic testing, and then what is, which bits are the icing and the cherry and so on the cake. So as far as genetic testing is concerned, I think that the minimum would be that people should have a FISH test, where they can find out what their translocations are and what some of the common deletions or amplifications are. Now, in order to have that, going back to what the lady was saying earlier, you have to have some abnormal cells in the bone marrow to be able to look at, okay? And so that's why it's important to have it done at the beginning, okay? If you haven't had it done at the beginning, then you definitely need it done at relapse. And as we get better with our treatments and we can direct our treatments to different groups, we should be thinking about testing when a patient relapses, which treatment's going to be most appropriate for them. As Gareth mentioned, at University of Arkansas, we also do this GEP test or MyPRS test as well. And we also do the cytogenetic test as well. So we do a kind of complete genetic test for all of our patients. But as I say, the minimum should be that FISH test. I'm going to hand over to Noopur now, I'm scared again.
No, I totally agree. So the thing to remember is a lot of people worry when the FISH test is not done at the time of diagnosis. What's done is done, so don't worry about that. Going forward, obviously when the disease comes back, absolutely get that bone marrow test done and get the FISH testing done. The translocations, which all of us have talked about this morning, are not going to change. Those translocations are there from the get-go, and they're going to be there pretty much throughout. What does change and what does evolve is some of the other genetic changes that we talked about, all of those acquiring of those mutations and so on and so forth. So, every place has its own institutional guidelines. So we certainly do FISH testing on all our samples. We will do cytogenetic testing on all our samples as well. The chances of cytogenetics being positive is a little bit lower, a lot lower in fact. And instead of doing the gene expression profiling, which Gareth and Faith do, we do the mutational profiling, which is a little it picks up mutations, and the reason we do that is to be able to figure out whether or not there are certain mutations that we can target. So it's more from a therapy standpoint for us to try and understand what it is that we can target, etc. So it's the test we use is a homegrown test which we've developed, but it's essentially we're doing the same things here.
So I think three coherent answers. I think it will all change. So I think cytogenetics, well, if you only get a test in 30% of the time, what's the point? Doesn't really help. It's gone. The FISH testing, it has to be done in a uniform fashion. You can get all of that information from a genetic test, and so it's all going to be about genetic testing going forward. Only difference is we know exactly what we should look for now, and so there are things called P53 mutations and amplification of chromosome 1q, which are the main drivers of really bad performing disease. And so I think, over the next year, that sort of approach is going to become uniform. So like me and Noopur's colleague Nikhil have been involved in this MGP project, which I'll tell you about later, which shows this.